Bonjour, merci de prendre vos places. C'est un plaisir pour moi de vous accueillir à cette conférence Fighting the Deadly TB Epidemic, organisée par Médecins sans frontières et plus précisément la Fondation MSF sur la recherche humanitaire. D'abord, merci d'être venus si nombreux et merci aux personnes qui sont en ligne. On m'a dit qu'il y avait une centaine de personnes inscrites en ligne. Okay, I'll switch to English because the official language of the conference is English. So I would especially like to thank the speakers. We have 4 speakers. Some of them came from very far. Sonia will give you details on them, on their CVs. Especially, I want to thank Professor SOW. She comes from Guinea-Conakry, and historically speaking, she has been the coordinator and she's supervised the first program of MSF Luxembourg that was a TB program in Guinea-Conakry, and the program she ran together with Jean-Claude Schneider, who is one of the founders of MSF Luxembourg, and who is sitting here in the first row, He's a pneumologist and who worked also on that program. And Sonia will present the other presenters. I also want to thank CHL for giving us the location. Besides the fact that Professor SOW has been connected with MSF Luxembourg for such a long period of time, she has other links to Luxembourg because her niece is head of cardiology at Centre Hospitalier de Luxembourg. She's also sitting. So now I leave the floor to Sonia Couprier, who is the coordinator of the Fondation and Recherche Humanitaire of MSF, and she present the program and also say what the foundation is doing. Thank you.
Vic, thank you very much. I'm not as tall as you. So my name is Sonia Couprier. I'm the coordinator of the MSF Foundation for Humanitarian Research. And well, I'm delighted to welcome you at the CHL, who is hosting us, and online. Before giving the floor to our guest, I would just say a few words about the foundation and why we decided to bring you together this evening to talk about tuberculosis. The foundation was set in 1993 by MSF Luxembourg, and in 2016, its mandate was reviewed to orientate more the foundation towards operational research and humanitarian research. So the aim is to promote humanitarian action and support operational research through various actions, like providing support for training in the field of public health, and particularly through operational research, and also awarding research grants, and providing a forum for debate on humanitarian issues by organizing events like the one from this evening. And now, why we wanted to talk about tuberculosis? Well, because if it's one of the biggest health crisis today, and also the second biggest killer after COVID. So it's quite important, and also because there are a million people around the world who are suffering from tuberculosis, but who are not always or not often enough diagnosed or treated. And also, So there's still a long way to go to find sustainable solutions that are accessible to everyone, and we need to mobilize all our forces to create synergies through partnerships, especially. But it's also because we are making progress, thanks in particular to many actors, including MSF. And MSF is providing care to the people with tuberculosis, but not only. It's also, MSF is also fighting on other fronts like research, but it's not known as well as its other activities. And but it's still getting things done in the fight against tuberculosis. So we wanted to highlight this, and so it's all of this that we wanted to share with you this evening, thanks to our speakers, in order to get a fuller picture of the situation and to understand the various ins and outs. So I'm very glad to give the floor to Amrish, Amrish Baidjoe, who's the director of the Luxembourgish unit for operational research, LuxOR unit. So it's both part of MSF Luxembourg and MSF. Well, it's part of MSF. Huh? That's that's enough. And he will be the co-host of this event tonight. And thank you very much, Amrish.
So good evening, everybody. I'm happy to see still a relatively full auditorium on a hot day like today. Yeah, sometimes an exemption. So indeed, hello, I'm Amrish and I'm the director of LuxOR, which is the operational research unit that is founded in MSF Luxembourg, but now works together with the wider movement on aspects of operational research. And I think some people might wonder, why does a medical organization such as MSF engage in operational research? Well, actually, it's quite logical. If you look at medical interventions, they are science-driven. And often we work on medical interventions that don't get sufficient attention. So it's logical that we also engage in research for multiple purposes. A, to strengthen the operational decision-making, to advance treatments for patients, but also to advocate that there are forgotten diseases that still cause a significant burden in large parts of the world, but maybe not in the parts of the world where the vast majority of research funding or funding overall is allocated. So very happy to see all of you here. I'm by background an infectious disease epidemiologist and microbiologist, so I know my way around the laboratory, but I must frankly admit that I know very little about TB. So for me, it's going to be as much of a learning experience as for all of you. My background is more in vector-borne diseases and respiratory diseases. So I made a small presentation on the general epidemiology around COVID, around TB, to better understand how big the problem is, but also as a gentle introduction into the excellent talks that the speakers of tonight have prepared for us. So I think I need to find some glasses, which I have somewhere in my pocket. I'm just turned 40, and that effect is very clearly visible now. So here you see a report from the WHO, which they produce on an annual basis, not just for tuberculosis, but malaria, for example. One of the diseases I work along on has these reports as well. And for me, this is an excellent report to kind of set the stage. Why is this an excellent report? Because almost all countries in the world feed their annual data into these reports. So it gives us an excellent way of assessing trends on a global frame, but it also puts what the challenges are, what the goals are that we have agreed as a global public health community, and how far we are from achieving those goals. So are we on track or not? So every year is a critical reflection that's being based on this report. So everything I present today comes from the global scope of researchers and public health people that kind of feed their data into this report. So none of this is original, to say so. So some basic numbers from the report. So the 2023 report was based from data from 192 countries, but almost all countries had this standardized at current in the world. A total of 1.3 million people died from TB in 2022, including 167,000 people that have HIV and have a compromised immune system, possibly because of that. Worldwide, TB is the second leading infectious killer after COVID-19, which is of course very fresh in our memories and is not gone from the stage at all at this time. And in 2022, an estimated of 10.6 million people fell ill with tuberculosis worldwide, including 5.8 million men, 3.5 million women, and 1.3 million children. TB is present in all countries and age groups. It's curable and preventable. And these are very important facts, of course, to underline. More importantly is also sometimes to kind of say that we present here point estimates. And so the true burden of a disease always likely to be an underestimate of the real burden of the disease. Another big challenge for TB, since we're talking about, microorganisms, are versions of that microorganism that are not so susceptible to most of the common drugs that we use. And they give rise to multi-drug resistant TB, which makes it incredibly challenging, to diagnose correctly patients in terms of what bacteria they are carrying, but also how to best treat them, but also making sure that those treatments are available. So only about 2 in 5 people worldwide got the drugs that they needed to treat these resistant infections. So that is a sad outcome to conclude. Global efforts to combat TB have saved an estimated 75 million lives since the year 2000. These are huge numbers. 13 billion is needed annually for TB prevention, diagnosis, and treatment to achieve the targets that have been agreed in 2018. If we are on the right track in terms of achieving these targets, well, I can make a parallel to malaria, where we have these targets as well, and the answer is almost always no, we're not on track because of the global commitments, especially in terms of funding, not being fulfilled, and in the end, on the political level, not meeting the agreements that we have agreed to in terms of investments. But ending the TB epidemic by 2030 is still among the health targets of the UN SDGs, the Sustainable Development Goals. Now, if you look at the trend since 2020, we also have to acknowledge that data became slightly more messy because reporting was not done so consistently during COVID because many health systems were overburdened. But also, at the same time, we know that much of the regular treatments and diagnosis for ongoing diseases in many parts of the world was interrupted as well. Despite that, since 2020, you can see a gentle increase in the trend when it comes to incidence of TB. And that is worrisome because that trend for many years was stable, which is not the optimistic outlook we're looking for, but increasing is definitely not the outlook we're looking for. If you look at the global burden of disease, 8 countries globally carry the burden, largest burden in terms of cases, which sometimes is a good thing because there you can focus really much of your attention. But overall, you looked at 30 countries, 87% carried 87% of that burden. And these were countries then at least where 100,000 cases were reported. I'm saying that it's a good thing in the sense that the amount of cases is not a good thing, but having this picture allows you to better target and focus your attention on the countries with the largest burdens. If you look at the trends on incidence on a country level between 2015 and 2022, 83 countries have seen reductions above 20%. Some countries have seen an increase. And this often depends also on how national programs are shaped to really keep that attention focus on a disease like TB. And we know that sometimes because of political instability or changes in national government, that health policies change as well, despite these high-level agreements, and they can directly have a severe impact on incidence of TB. This is something we see with a disease like malaria as well. That's why I think that TB and malaria, to some extent, share some similarities. So the answer that we're trying to answer today, are we on track to end the TB epidemic? And for this, I'm going to start inviting a really impressive panel that we've managed to collect here in Luxembourg. We're going to continue with the presentation. It's more of a technicality, one after the other, which means that we will save all the time for questions at the end. But it's kind of to bring all the different perspectives of the speakers together so that we can have more informed questions. The first speaker I would like to introduce is Professor So. Please welcome her warmly. Yeah.
Good afternoon. I'm very happy to be here, and I would like to thank the organizers, mainly Dr. Vic, Sonia, and the others for having invited me. I think I will continue to speak French. It will be easier, and as I have a lot to say, it will be quicker. Otherwise, I will take a lot of time. So please accept me to speak French, but the slides are in English. Okay? Thank you. C'est bon, vous m'entendez? Oui, je vais vous parler de la lutte contre la tuberculose en Afrique, mais particulièrement de la contribution des partenaires dans cette lutte anti-tuberculose. Mais comme vous allez le constater, je ferai surtout beaucoup d'histoires parce que je sais que beaucoup dans cette salle, au moment où moi je commençais la lutte contre la tuberculose, je ne sais même pas si leurs parents étaient nés. Donc je présenterai selon le plan que vous voyez. Je ne vais pas m'appesantir dessus puisque nous n'avons pas beaucoup de temps. Et donc, je vais y aller. J'ai été impliquée dans la lutte contre la tuberculose depuis près de 50 ans ou plus. Et ce qui m'a permis d'être témoin de l'évolution de cette lutte anti-tuberculeuse depuis le départ. Parce que dans les années 60, il y avait rien. C'est petit à petit qu'on a mis en place des activités de lutte contre la tuberculose. Et donc, j'ai été témoin de l'évolution de cette lutte depuis un seul centre dans chaque pays jusqu'à la mise en place des programmes nationaux de lutte contre la tuberculose qui sont fonctionnels dans tous les pays. Et c'est grâce à ces programmes que vous avez les données que Dr. Amrish vous a montré sur le rapport mondial de la tuberculose. Et pour l'histoire, même ce rapport, tout au début, il y avait très peu de pays qui fournissaient des données, comme il l'a dit, mais à présent, tous les pays fournissent des données et plusieurs ont été aidés dans la mise en place, dans l'amélioration de leur système de surveillance pour que ces données soient fiables, qu'elles remontent jusqu'à Genève et qu'elles permettent de faire ce rapport. Donc, vous avez vu qu'il y a un long chemin à faire, mais ce chemin a été pavé par la participation cruciale des partenaires qui nous ont appuyés depuis la mise en place des programmes jusqu'à l'heure actuelle dans la continuation de l'exécution de ces programmes pour atteindre les résultats que nous escomptons qu'il a présentés et sur lesquels nous reviendrons. Et pour illustrer l'appui des partenaires, je vais commencer vraiment dans l'histoire et je vais remonter très loin. Et pour cela, je citerai l'exemple de la Guinée. Et c'est ce cas que nous allons voir progressivement. Je pense que là, vous avez la Guinée que vous voyez donc à votre droite. Et moi, des années, il y a longtemps, avec certaines de mes patientes. Donc, l'histoire de la lutte contre la tuberculose en Guinée, je ne commence pas. Je vous parle d'avant 1981. Et avant 1981, Et vous voyez ces deux bâtiments que vous avez là, c'était les bâtiments qui abritaient les malades tuberculeux. En 1981, il existait un seul centre de traitement de la tuberculose en Guinée. On l'appelait Obasai, c'est-à-dire de l'autre côté, the other side. C'est la déformation du terme other side, pour témoigner du rejet et de la stigmatisation dont ces malades étaient victimes. À cette époque, les médicaments, les malades devaient les payer dans les pharmacies et il y avait souvent des ruptures de stock. Et dans ces conditions, très peu de patients arrivaient à Conakry pour se faire traiter. La majorité des malades mouraient sans traitement dans des situations de cachexie terminale ou dans des hémoptysies foudroyantes. C'est pourquoi, à l'époque, les gens disaient que le diagnostic de tuberculose signifiait un arrêt de mort, une sentence de mort. Donc, à l'époque, au Bassa, il n'avait ni médecin ni infirmier. Donc, c'est avec le temps que vous verrez qu'il y en a eu beaucoup, mais je passerai sous silence et actuellement, vous verrez comment ça a évolué. À l'époque, il n'y avait pas de laboratoire et le seul outil de diagnostic était la radioscopie. Et je suis sûre que plusieurs d'entre vous ici, qui a jamais vu un appareil de radioscopie dans la salle? Ah, ben, il y a quand même quelques-uns. Vous les avez utilisés ou bien vous les avez vus seulement? Je pense que vous les avez vus seulement. Donc, moi, je les ai utilisés. À l'époque, il n'y avait que le seul outil de diagnostic qu'on avait, plus de la clinique. Donc, tous les jours, je faisais 30 à 50 radioscopies. Et c'est pour ça que je dis, mais c'est un miracle de Dieu que je n'ai pas présenté de leucémie à l'époque à cause de cette irradiation massive ou avoir un enfant avec des malformations congénitales parce que j'ai eu quand même un enfant à cette période-là. Donc, vous voyez que c'était pas facile, c'était extrêmement difficile. Et ces bâtiments, j'en ai fait la photo en 1974 quand j'ai commencé dans le service. Rapidement, je ne vais pas... L'année 1981 a été cruciale. D'abord, le ministère de la Santé a donné la gratuité des soins pour les tuberculeux. Et ça a eu lieu au terme d'une très grosse bagarre que j'ai eue lors de cette première conférence nationale de la santé. En particulier, il y a plusieurs anecdotes que je peux raconter. Il y a une, peut-être, je vais la raconter parce que je pense que ça va vous intéresser. Il y a une dame qui représentait le syndicat et qui a pris la parole. Elle a dit, il faut débarrasser Conakry de cette sale maladie. Alors, l'après-midi, moi aussi, j'étais tellement fâchée. Je voulais répondre tout de suite, mais je me suis calmée, j'ai attendu l'après-midi. Quand on m'a donné la parole pour parler du service, j'en ai parlé, j'ai dépeint la situation. Je leur ai dit, pour finir, je demande l'appui de tout le monde, sauf celui de la CNTG qui veut envoyer les tuberculeux au crématoire. La salle a éclaté, ça a été un brouhaha terrible. Mais ça m'a quand même amené à obtenir les médicaments et le traitement et c'était intéressant. Et parallèlement, bon, en 81, nous avons adhéré à l'Union internationale contre la tuberculose que vous connaissez tous, je ne vais pas insister. Mais en 82, il y a eu l'arrivée du premier partenaire, de la première ONG qui s'est impliquée dans la lutte contre la tuberculose en Guinée, c'est la mission fil-africaine suisse. Je ne sais pas, certains la connaissent parce que certainement on la voit dans les réunions. Et aussi en 86, j'ai reçu le premier don de médicaments antituberculeux par l'Union, la directrice générale, Dr Annick Rouillon, le directeur, Dr Karel Stiblo, le directeur scientifique. Ils m'ont donné des médicaments, ce qui m'a permis de mettre en place le premier traitement avec suffisamment de médicaments pour guérir les malades. En 86, donc on a réhabilité le service de pneumologie, l'hôpital Ignasti, et comme on dit, le Obasai a bénéficié aussi de la réhabilitation grâce à cette réhabilitation générale de l'hôpital. Et en 88, c'est l'arrivée aussi de MSF Luxembourg qui a été donc le deuxième partenaire à nous appuyer. C'est pour ça que j'ai été tellement contente de revoir Dr Jean-Claude Schneider. Je ne sais pas où est-ce qu'il s'est caché. Tu t'es caché? Oui, on a commencé ensemble. L'enthousiasme, on faisait beaucoup avec peu de moyens, mais on faisait beaucoup. Donc, ils sont venus, ils nous ont dit qu'ils allaient nous appuyer. Pour la ville de Conakry, on a réhabilité le dispensaire où ils ont mis un appareil de radio, donc fini les scopies, un laboratoire et les médicaments et la formation. Donc, on a contribué à faire un peu la lutte anti-tuberculose dans la ville de Conakry soit en place. Et après le dispensaire du port, on a mis en place dans d'autres centres, dans les autres districts de la ville de Conakry. Vous avez à votre droite les bâtiments actuels du service de pneumophysio. Les bâtiments que vous aviez vus au départ ont été totalement détruits parce qu'on ne pouvait rien en faire. Il fallait vraiment les détruire. Ils ont été détruits. On a construit ces nouveaux bâtiments et je pense que maintenant, ils sont bien. En 1990, nous avons élaboré le programme national de lutte contre la tuberculose avec l'appui de l'OMS et on a mis en place le premier plan stratégique de 1991-1995 qui permettait justement d'impliquer toutes les préfectures, nous on appelle préfectures, les districts, faire en sorte qu'il y ait un centre de diagnostic et de traitement dans chaque district. Ça, c'était un grand pas de gagné. On a pu couvrir le pays en 1995, au début de l'année, et vers le quatrième trimestre de 1995, nous avons fait la première revue du programme avec l'OMS et les partenaires qui étaient présents. Et on a vu que les résultats étaient bons. On a mis un plan pour l'extension. Cette extension mettait l'accent sur le renforcement de la décentralisation du diagnostic et du traitement, en impliquant les centres de santé dans la sélection et le transport des crachats pour permettre et assurer le traitement des malades dans les centres de santé, ce qui nous a permis de rapprocher le plus possible le traitement des malades. Donc, on a en plus le docteur Amrish sera content de voir que je parle du laboratoire de référence. Il sait ce que ça représente parce lorsqu'on a mis un réseau de laboratoires de microscopie en place, il faut avoir un laboratoire de référence, donc un laboratoire national de référence qui supervise le réseau de laboratoires et qui fait des formations, qui fait des supervisions et qui assure l'approvisionnement en réactifs à l'époque. Vous voyez le laboratoire national de référence donc à gauche du bâtiment. C'est le bâtiment donc a été construit, c'est la conjonction des efforts du gouvernement qui a construit le bâtiment et le partenaire, l'ONG, l'Association française Raoul Poloro, qui a apporté les équipements et les réactifs, a assuré la formation et la supervision du laboratoire pendant plusieurs années. Et comme vous le verrez, contrairement à ce que vous aviez vu au début, maintenant le service a été humanisé, il y a tout ce que vous voulez, il y a des fleurs et je dois vous avouer que du mouroir, vous avez vu, en 1974, on est passé au miroir que vous avez maintenant. De sorte que quand l'hôpital Ignastine reçoit des visiteurs, le service qu'on leur demande de visiter en premier lieu, c'est le service de pneumophysiologie, celui que tout le monde fuyait dans le passé. Ici, rapidement, je vous montre en chiffres comment ça a évolué. Donc, vous voyez, c'est très vieux. Hein? Vous parlez du rapport de 2023, je reviens, vous avez vu, en 1974, il n'y avait qu'un seul centre de diagnostic. 80% des malades soit mouraient, soit disparaissaient. En 90, il y avait 12 centres de diagnostic et de traitement et on a quand même eu 1988 cas diagnostiqués. En 95, on est arrivé à 3523, 38 centres de diagnostic et 160 centres de santé impliqués dans ce fameux transport des spécimens dont je vous ai parlé. En 2001, ça a encore augmenté et nous sommes arrivés à 45 centres de diagnostic et de traitement et 400 centres de santé impliqués. Ici, j'ai résumé donc l'ensemble des partenaires qui sont intervenus en Guinée. Sonia, si le temps presse, il faudra toujours me rappeler, hein, parce que si vous me laissez, je parlerai longtemps parce que c'est quelque chose que j'ai vécu et que je connais bien. Donc, si vous voulez, je vous fais seulement cette liste et je passe à d'autres. L'OMS a commencé à nous appuyer en 90, MSF a commencé à nous appuyer donc à 88 et ainsi de suite. Donc, vous voyez comment ça a évolué et tous ces partenaires se donnaient la main pour vraiment mettre en place le programme national de lutte contre la tuberculose, qui a été pendant des années le programme modèle de l'OMS. Et c'est là qu'on formait les gens à l'utilisation de la stratégie DOTS. Ils venaient de tous les pays et en Guinée, ils se formaient là et ils faisaient des visites du site pour voir ce que nous avons fait. Dans les autres pays africains, je passerai très vite si vous voulez. Et au Sénégal, il y avait une ONG norvégienne qui s'appelle la LHL. Au Mali, c'est l'Union. Et en Côte d'Ivoire, je vais mettre un petit accent sur la Côte d'Ivoire parce que c'était à l'époque le seul pays qui achetait les médicaments antituberculeux pour son pays propre. Donc, c'est le président Houphouët-Boigny qui avait donné les instructions pour qu'on leur donne de l'argent pour qu'ils achètent les médicaments. Au Togo, il y avait la DAO. Au Bénin, c'est l'Union. En RDC, la Fondation d'Amiens, je sais peut-être. Et donc, si on passe à 1989, je vais développer un peu le rôle de l'Union et le rôle de l'OMS. En 1989, on a nommé Dr Kouchi à la tête de l'unité tuberculose. Il a lancé justement ce fameux GTD, Programme mondial tuberculose. C'est lui qui l'a lancé. Après, il est mort quelque temps et après, vous avez vu qu'on est revenu là-dessus. Donc, entre 89 et 98, il a lancé, GTB a lancé et assuré la large promotion de cette fameuse stratégie DOTS. Et l'OMS continue à appuyer jusqu'à présent. Et au niveau de l'Union, je pense que tout le monde connaît l'Union, la découverte de la rifampicine, avec ajouté aux autres médicaments qui existaient, ceci a permis de faire les recherches, parce que je pense que c'est important, la recherche, parce que c'est elle qui a permis de faire avancer, de faire progresser la lutte contre la tuberculose. Donc, ils ont fait les recherches pour aboutir au régime court que vous connaissez actuellement, 6 mois, et actuellement on est à 4 mois, et on espère qu'on viendra un jour à 1 mois de traitement. Et j'ai une amie à Londres qui s'appelle Amina Gendani, elle dit qu'elle souhaite être vivante jusqu'à ce qu'elle voit le régime de traitement de tuberculose à 1 mois. C'est le fameux Karel Stiblo que vous connaissez, je passe. Bon, ici, j'insisterai sur un élément, c'est les revues de programmes qui sont institutionnalisées dans tous les pays et qui permettent donc de voir ce qui est fait et de fixer l'orientation vers les prochaines années. Et tous les partenaires y participent. Ça, c'est un outil puissant de mobilisation. Puis, il y a eu l'arrivée du Fonds mondial, vous connaissez tous, il y a eu beaucoup d'argent et entre 2015 et maintenant, on va parler du changement qu'il y a eu. Nous avons mis en place, avec l'appui de TDR, les plateformes WARN en 2015. Et au départ, on insistait beaucoup sur la recherche et ça a permis d'aider les pays africains à mettre en place des unités de recherche, parce qu'avant, les programmes disaient non, la recherche, ça c'est pour les universitaires, c'est pas pour nous. Mais ils ont compris que c'est pour eux. Et donc, il y a eu dans chaque pays un point focal recherche. Ils ont mis une task force multidisciplinaire sur la recherche et ils ont fait des plans stratégiques de la recherche et qu'ils mettent actuellement en œuvre. Il y a eu beaucoup d'avancées, mais c'est surtout la recherche opérationnelle et ça, c'est extrêmement important. En 2018, l'entité d'Afrique centrale a compris a été conquise par ce qui se faisait en Afrique de l'Ouest et ils ont demandé à adhérer et on a donc créé CARN et on a fusionné les deux avec un seul secrétariat exécutif qui est tenu par le PNT du Bénin. En 2023, ceux d'Afrique de l'Est, d'Afrique australe aussi, ont voulu s'impliquer et donc maintenant on a le réseau panafricain des programmes nationaux de lutte contre la tuberculose qui vise à intensifier donc la lutte contre la tuberculose et aussi la recherche pour essayer d'aboutir au réseau que le modérateur à l'atteinte des objectifs de la stratégie modérateur a cité tout à l'heure. Donc ici, World TB, c'est 16 pays d'Afrique de l'Ouest, vous les voyez sur la carte. Ici, c'est 16 pays plus 11 pays d'Afrique centrale et le tout coordonné par le secrétariat qui se trouve à Cotonou. Donc, ces 27 pays ont une population de 652 millions d'habitants. Comme vous le voyez, ils parlent français, anglais, espagnol et portugais. Et en 2022, 830 000 cas de tuberculose ont été notifiés à l'OMS. Et donc, vous voyez, il reste un gap de 470 000 cas à identifier et à traiter. Et vous voyez, le taux de succès du traitement est très faible pour pouvoir parvenir à plus de 95% pour qu'on espère relancer la tendance. Donc, ici, vous avez les objectifs de CAR. Je pense que je vais avancer pour vous les lisiez seuls. Et donc, il y a eu beaucoup d'activités qui ont été menées. Je ne cite qu'une, c'est le renforcement de la visibilité des programmes. Et comme vous le voyez, cette visibilité, c'est non seulement entre les programmes eux-mêmes, mais aussi entre les programmes et les partenaires. Et donc, on a un site web, on a une page Facebook, newsletter, etc. Et on fait beaucoup de webinaires depuis Covid, que Covid est arrivé. Et donc, l'impact a été que ça a permis une meilleure accessibilité des programmes pour les partenaires et surtout une très forte collaboration entre les programmes eux-mêmes et beaucoup d'échanges qui se passent principalement au cours de la réunion annuelle où chacun vient exposer ses problèmes et aussi on discute beaucoup parce qu'il y a des problèmes, des défis programmatiques que les pays doivent chercher, par exemple les tuberculoses transfrontalières, les tuberculoses dans les pays du Sahel où il y a beaucoup d'insécurité, etc. Et vous avez vu que la recherche est au premier plan. Donc, depuis que le Fonds mondial a commencé, tous les pays actuellement ont bénéficié du Fonds mondial, mais les autres partenaires jouent aussi un rôle extrêmement important parce qu'ils aident, ils sont devenus partenaires techniques et ils aident, ils facilitent l'élaboration des grants parce que la procédure est assez complexe. Et donc, on souhaite que les partenaires maintiennent leur appui non seulement au pays, mais aussi à notre plateforme Warm, Carn et TB, pour que ces plateformes aussi appuient les pays et pour qu'on puisse atteindre les objectifs fixés par la stratégie, dans la stratégie NDP. Bon, ici, je vais aller vite. Ce que nous souhaitons aussi, c'est bien beau que les partenaires trouvent aussi des répondants dans le pays et il faut que les institutions africaines régionales s'impliquent dans la lutte contre la tuberculose et mettent des ressources pour que, ensemble, avec les partenaires, vous savez, chez nous, il y a un proverbe qui dit que lorsqu'on te lave le dos, tu dois te laver le ventre pour que tu sois propre. Donc, il faut que les institutions régionales s'impliquent parce qu'il y a toujours un gros problème de financement et le modérateur en a parlé avec tous ces cas attendus, tous ces problèmes à résoudre. Et donc, si c'est simplement, on doit finaliser le plan 2025-2030, on doit intensifier le plaidoyer au niveau de ces institutions. Et puis, on doit aussi impulser le soutien à la recherche, comme je vous l'ai dit. Les partenaires doivent s'impliquer. Et je pense que MSF certainement s'implique, je ne sais pas dans quel pays, mais doit s'impliquer parce que la recherche, il y a beaucoup de choses à faire pour aider à progresser vers les objectifs d'NDP. Et donc, en conclusion, notre plateforme est une plateforme privilégiée pour avoir des informations sur les programmes, mais aussi plateforme qui facilite la collaboration avec les partenaires. Mais il est important toujours de stimuler l'appui des partenaires pour que non seulement les programmes fassent leur travail, mais que les plateformes aussi parviennent à continuer à coordonner. Donc, c'est la collaboration harmonieuse entre les partenaires et les programmes qui va contribuer à la réalisation des objectifs NDP. Voilà, je vous remercie.
Okay, that was a really impressive historical overview of the early days to where we are now, with a lot of capacity available in many countries, as exemplified by Guinea. But it's still challenges remaining as well. Also clearly shows the high value of networks on a national level, on a regional level, and on a global level, which of course sometimes come with challenges as well. Especially when it comes to funding and funding streams and that highly influence what national programs can actually do. Dr. So many thanks for this presentation. I rush. I forgot to also do a gentle, a proper introduction of your very impressive career, which is also having really strong links to Luxembourg. So I was very happy to see that as well. So yeah, thanks again. We're going to our second speaker. She's Gabriella. I'll do a quick introduction because I have a nice compilation of bios which I'll introduce, but just for the general audience that of course doesn't know you yet. So she's an infectious disease physician and with a lot of expertise in TB, and the vast majority of her career, she also worked on TB on many angles, from the medical technical questions that we have to nowadays on issues of access, which are incredibly important to be mapped. And it's a nice combination of where you can combine medical expertise, but also complexity about international law, lobbying, and all these elements that are included in there. So I invite her also to that, because I know you have an excellent presentation also for us. So here you go.
So it's not easy to talk after you, Professor. But I would like to thank you before starting the focus of the presentation, that is on research and advocacy and how we use these tools, by saying that you mentioned stigma and discrimination, and it's not only something that happened 40 years ago. Unfortunately, it happens still now, and we need to fight it. And we don't need to forget this. In Luxembourg, in Europe, in Africa, in India, everywhere. It does not only apply to TB, it applies to HIV. I saw here personally working with substance abuse patients that this happens. This takes patients away. It's a barrier, and it's a reason why also in TB we do not have enough access to care for our patients. So this had nothing to do with my presentation. But I really appreciate it. So my very difficult goal, because I'm Italian, I speak a lot. So it would be to try in 15 minutes, but I've been told I can use 20, to share with you a bit. It will not be comprehensive, but you can reach out to me. I will share presentations and anything I'm passionate about TB. A bit of the research initiatives. Some of them have really changed the way we treat and we address TB. And as Amrish was saying, also a bit of the advocacy that we do. And to see how we use these tools. These are very powerful tools to change policy, to improve access to care, especially for the most vulnerable ones. So that's exactly the same. It's the title. And so I really had to make a choice, because the work of MSF in TB for over 40 years is massive. The research and the advocacy that we've been doing in close partnerships with others is also quite big. So I thought to talk to you about two specific topics in terms of TB. So pediatric tuberculosis, what we're doing, where the gaps are, and what we're doing to address them, both from an advocacy as research perspective, and drug-resistant TB. And again, we will see a bit how we use these results to change policy, and maybe also a call for action to people online and to people here in Luxembourg, to say that you don't need to go to Guinea or to India or to Poland or to South Africa to contribute, to make a change. We can really do it here, okay? Each one of us. That was the last slide, but I anticipated. Okay, so I will go back to what Amrish already shared, so some numbers. And I do hope you get shocked as me every year when I read this global TB report to see that numbers are frightening. COVID, I mean, there was, as Amrish was saying, the situation was starting to get better, and then we got back off track with the COVID epidemics. And now the reasons for these numbers, I mean, 10 million cases, 2 out of 5 patients with drug-resistant tuberculosis, which is a massive public health threat, they do not have access to treatment in the world. We could speak for hours about why this happens, but my colleagues from the Access Campaign managed to translate into an infographic the stats. We get sometimes bored with the stats, but when we see that 1 child dies of tuberculosis every 3 minutes, we should really ask ourselves why this keeps happening. So going back to MSF work, this will be a bit the focus. We already touched base on this in the sense that MSF started providing direct care to TB, I believe 40 or 50 years ago, before I joined, much more, I mean, 50 years ago, I don't think so there, but anyway, 4 decades ago. We started over the last decades using more and more research and other advocacy tools together with the direct implementation. And to do this, because the MSF is not only a medical organization, it's also the key mandate is the témoignage, speaking out. So we need to contribute to knowledge, to awareness, to change, And we do this in different ways. But in TB is particularly, I would say, an important topic. So the focus of our work, we do not discriminate, of course, on populations, but there is a special focus, I would say, on children and adolescents, especially in the last years. Of course, conflict zones, refugees, migration, and we might touch base on that during the debate. Prisons, which are the hotspot of TB everywhere in the world, with the prevalence incidence rates up to 100 times what we have in the community. And then we look also as MSF since a long time on drug-resistant tuberculosis, including its most complex forms. Shorter regimens, I will keep mentioning short, because as you were saying, it's not only on TB, but who wants a 2 years treatment to treat my child with a child with drug-resistant tuberculosis? No one. 6 months is still too long. 4 months is still too long. So we dream about super short regimens. Anyway, just a few numbers which may not say much to you, but across every year we have the medical activity report. And I will just mention that, okay, activities are much broader than just treating patients, much, much broader. But we have about almost 20,000 patients are started on treatment in collaboration with the MOH of the countries where we work, and 2,600 patients started on drug-resistant TB. And this is a big, big number. You can imagine from the first slide from Amrish, so these patients come from everywhere where MSF works. But I look at Joanna, my colleague, who worked in India, and a big proportion of these patients are treated in India, in Mumbai, where MSF has had an amazing project for a long, long time. Unfortunately, it's closing this year, but that's another debate. And so next year we might see numbers a bit smaller. Just a thought, it's not a thought, it's more how can I say, the concept behind pushing for shorter regimens across all diseases, but in TB, this is particularly important. So if we have shorter regimens, patients and families can go back to their work, to their home much sooner. Poverty and TB, they're closely connected, and TB has a major devastating impact. We call this catastrophic cost. So to have a shorter regimen can reduce this catastrophic cost. It's more easy to finish the treatment. We accuse patients, we used to call them defaulters. That was very stigmatizing as well. Now we call them lost to follow up. And we cannot call TB suspect, we call them presumed TB. But all this contributes, so it's good that people think about it. And a shorter regimen is more tolerable. People accept it much more easy. They are more likely to complete the treatment. And also from a health system perspective, you need less human resources, you need less money, you can use this money to do other activities. And in some countries that really struggle with budget and finance and HR, I think this can be a game changer. So I will start with Sonia, feel free to tell me, cut. The first focus is pediatric TB. Why do children die 1 every 3 minutes? The reasons are many, but the key gap in the TB cascade in children is the diagnosis. We do not have an accurate, easy to use, non-sputum based, because children, they really have difficulties to expectorate. Oh, I didn't mean to do that. Okay. To diagnose children. Of course, if we don't diagnose them, we cannot even start them on treatment. There is all the prevention part that also is super important, but if we do not look for cases, for contacts and so on, we will never find them. So the detection gap is the biggest killer, I would say, in the pediatric TB epidemics. But then even the ones we diagnose, not everyone is started on treatment. Not everyone will continue the treatment, and so on. So we have since 2022 some very good evidence-based guidelines from WHO, really focusing on children that say a bunch of things. I won't go into the details. You will see them in the slides. But we can diagnose TB in a more easy way, also on clinical basis. You don't need to have a CT scan, or you don't need to go to have your child go under bronchoscopy to diagnose and treat TB. We have access to some tests. They're very good, experts, chest X-ray, but even if you're in a remote health center in Guinea, do they really have that? I've seen very many challenges there. So, and then we have recommendations on shorter treatments. We can give 4 months of treatment instead of 6. Maybe it doesn't seem a big game changer for you, but it is for certain categories of kids. And we can treat TB infection, so the prevention part, with only 3 months, and actually also with 1 month TPD. So what's happening? This is not done. Countries lag behind. Challenges are massive everywhere. So MSF, this is an example of a big initiative, has decided and approved a big project. It's called TACTIC, Test, Avoid, Cure TB in Children. And the goal is to really change the way we manage TB across our projects. With this continues to go along. With 3 components: implementation, operational research to support the results, to bring even more evidence, and advocacy. There's going to be a pediatric survey, will be released in September, on policy and implementation. Do countries have the tools? We included Poland in this survey. Poland is in Europe. We didn't include Luxembourg because of many reasons, but probably if we were to ask Luxembourg, do you have all these policies in line with the latest, do you have these drugs? I already know, because I'm following a European dossier, the answer is no. So Luxembourg, as many other European countries, do not have all the tools to treat appropriately with the best standards of care tuberculosis in children. This is a bit the map of where this TACTIC project has started already, its implementation and the operational research. You can see 14 countries across all over, especially very difficult there is Guinea as well. And in certain countries, it's harder because of HR and many other reasons. So I will just do a very brief snapshot of 2 operational research initiatives related to pediatric TB and how we are going to use these results, okay? So there are several operational research initiatives linked to this TACTIC project, but a key one is the diagnostic performance. So research looking into diagnostic performance and feasibility of the two new WHO treatment decision algorithms for pulmonary TB in children. So one, I'm just giving the examples of 2 sites, one in Nigeria. It's a nutritional project in nutrition settings, malnutrition settings actually, up to some studies show that up to 23% of kids have tuberculosis. And I can tell you, as MSF, we do not diagnose those. There is fear, there is reluctancy, there are different reasons. So we really need to push for that. I will summarize the results of the Nigeria study, okay, that has been also recently presented in another event. So basically, since they started applying in a very well-monitored and closed way, so through operational research, after, of course, conducting trainings, ensuring the tools were there, they saw a massive increase in number of kids that on the right, that were presumed with TB, for which then we thought, okay, we need to exclude, to rule out, or to diagnose. And after this, in numbers of children started diagnosed and started on treatment over the last year. So this is how we hope that not only we will bring these results to policymakers, WHO, and other partners, of course, it's in collaboration with the MOH,
but also what you leave. What I think the key point is, after you conduct a research, you leave behind staff that is much more trained, the tools, the awareness. So there are things that even after the research finish are very important. I will skip this because it's just a preliminary results, but just to say that also in Guinea, the same study is ongoing, and they're doing a very good job. So I will stop and ask 5 minutes. I need to rush. Because this, if we talk about drug-resistant TB, and this is where MSF has really changed the world, I would say. Background, until 10 years ago, the recommendations, and unfortunately the situation is still this one in many countries today, but the recommendations of WHO included 24 months of treatment to treat drug-resistant tuberculosis forms, even the most easy one, like MDR, and which I'm sure I can read. Yes, 14,000 pills plus 6-8 months of injectable that would cause loss of earrings and nephrotoxicity and a bunch of other things. Not only for adults, also for kids. So let's say that there was a desert and only 1 out of 4 would get cured. In this catastrophic situation, MSF was working in these situations. We all saw this, Jill there, myself, and many others, Joanna, and especially our patients, our clinicians on the ground, our nurses. In this crazy situation, desert of access to quality care for drug-resistant TB, something happens. There are 2 new drugs that after 50 years, no one cares about TB, so there is no research and development. After 50 years, we have 2 new drugs. And then a 3rd one, which was not fully approved, but that's okay. And so MSF, big brains in collaboration with others, with Harvard, with Epicentro, with lots of partners and so on, people start saying, we need to do something. Even if randomized clinical trials, they are super big, massive things. It's not what MSF usually does. We've been doing a bit in HIV, but we need to do something. So to make it short, brief story, 3 clinical trials are started, randomized clinical trials, complex, expensive, and maybe afterwards you will have questions. The first one came out and was published on New England 2 years ago, 2022, practical. It changes the treatment from 18 months, well, then it became in some cases 9, 12 months, okay, but to 6 months only. All oral, and in the picture you can see the difference in terms of pill burden compared to what we had as latest recommendation to what we have now. So 6 months, but we cannot give this to children. That's a pity, several reasons. But good job MSF, good job MSF so-called OCA, our colleagues from Amsterdam, because this has changed the way we treat TB. It's the first recommended regimen as per WHO in the whole world. We have problems of access. That's another issue because money, the drugs are expensive. This is another clinical trial. It's very close to my heart because I'm part of the team, but it's called NTB. Again, the goal is to find new treatments. The study finished, one of the 2 clinical trials, and it was super complex. I will just go to the slide here. So we conducted it in 7 countries, all these again in collaboration with the MOH and with key partners that you can see maybe in the previous slide. I want to mention them. Yes, you see all those partners in health, of course, MSF, IRD, Harvard, Epicentro, et cetera, and financed by Unitaid and by MSF. So big study, long timeline. It's very complex to make randomized clinical trials when you have to enroll almost 800 participants, but finally finished and the results were presented. We are going to publish soon. It's been accepted on New England and we expect WHO recommendations, so a policy change next month. Let's cross finger. Yeah, thank you all. And no. Well, thank you all to the team. No. I swear I have one last point, which will then link to the next presentations. So I was mentioning before, TB is not only affecting Southeast Asia, Sub-Saharan Africa, and the usual suspects. We have TB Europe. We managed to get it down a bit, but now it's coming up, and also not only because of the Ukrainian war, the prevalence is very high in Ukraine. Patients are fleeing, in other countries, and so I'm sure the Luxembourg had quite a few as well. But you need to know this: the drugs. So I will tell you, pediatric fixed dose combination, which allow to treat a child with 2 dispersible tablets for 6 months. We don't have them in Europe. Shocking for me as well. After 15 years of TB, last year I found out this. We do not. So I don't know if anyone has treated a child with TB in Luxembourg, but you probably give 11 or 18 tablets. Yeah, but 11 tablets, all separated, not child-friendly or something like that. Rifapentin, which allows for shorter preventative treatment. Do we have it in Europe? Is it registered? No, it's not. We discovered it in Italy, and we don't have access to it in Europe, except with some flexibility mechanism and so on. So the drugs I mentioned, DRTB drugs, do you know how much they cost? You don't want to. They can cost up to 100 times, even more actually, what they cost in low and middle income countries. And we don't know how much they cost here, because each country in Europe negotiates with Johnson & Johnson and with the others its own price. So there is a complete lack of transparency. They are registered, but many countries, Germany recently told us, we cannot afford to treat all these patients with DRTB that came from Ukraine and others. So just to say, medicine should be accessible and should not be a luxury. And we had, for Sonia kills me, I want to mention because it will touch base with the next presentation. We had recently a multi-partner workshop in Berlin organized by WHO, where all European and also UK and Norway and other countries have been invited to try to find solutions to registration of rifapentin, registration of fixed dose combination for children and adults, and the high price of DRTB drugs. Unfortunately, Luxembourg, I think, couldn't send anyone, but it's been an amazing workshop, and we have a lot of events that are coming now to follow up. As MSF, as Access Campaign, we're really pushing on this dossier. So not only low, middle income countries, that's the focus for sure, but also we don't want to leave anyone behind. So you can do your bit, go home, check, do you have these drugs? Please demand, and your country needs to make the efforts to find solutions together with the regulatory agencies and all of us. Now it's, thank you.
Thank you, Gabriella, for a very comprehensive overview. Also a bit of like why it's important that we don't just engage in treating patients, but also constantly try to move the line to new interventions for diseases that are sometimes way too much ignored, but also keep on arguing for access to new drug regimens, to diagnostics and to appropriate treatments. Now we go to an aspect around vulnerable populations. So I would like to also introduce our next speaker, Dr. Joanna, who we work with. She's now currently a medical coordinator for MSF in Poland, but she worked 16 years already with MSF, of which 9 years as a medical coordinator. So very impressive resume in terms of like the many different contexts that she has worked and a rich amount of experience. So save a little bit of time and give you more time for the presentation. I'm going to hand it over quickly to you.
Thank you very much. I will try to regain the time that we are behind the schedule. And I will be speaking about our project in Poland that it's focusing on TB and drug resistance TB in the population affected by conflict, and we mainly focus on the Ukrainian conflict. So as you all know, in 2022, the full-scale invasion started in Ukraine, and it of course affected as well the whole health structure. So we speak about TB diagnostic, TB care, so destruction of the infrastructure. We speak about rupture of stock of the medicines. We speak about displacement of the medical staff, of course, as well displacement of patients. We speak as well about transmission because, of course, the people sheltering together in crowded areas for several weeks. We speak as well about stress, malnutrition that, of course, as well affect the development of the disease. So if we look to Poland context, so first maybe let's look to the numbers comparing TB in Poland and in Ukraine. So Ukraine has 7 times higher incidence than it is in Poland, but what's important is actually proportion between drug resistance and drug sensitive TB, which is 30 times higher in Ukraine than it is in Poland. Because in Ukraine, 1/3 of TB patients, they have the drug resistance TB. And if you see the numbers, and those are the pre-COVID numbers, so actually in Ukraine, there are 10 times more drug resistance TB cases than in the whole European Union. So if we look now to the numbers of the refugees that arrive in Poland, so they have been counted in millions, from which 2 million were actually registered under international protection. Currently, only 1 million of those stay in Poland. Many of them, they moved all to different countries, or they simply come back to Ukraine. But as well in Poland, we already had about 1 million of Ukrainians that arrived when the war actually started in 2014. So in the beginning of 2022, WHO made estimation of how many patients we could expect among those refugee population. And if you look to the drug resistance cases, it's actually 4 times more than we usually have every year in Poland. So then let's maybe look to which kind of the challenges those refugees actually face. So let's not forget they're fleeing the war. So for sure, health is not the priority. The most important is to find shelter. It's to find a way of income, to find, to solve the administrative situation. Language is, of course, a big barrier as well. And then how to navigate in the whole health system that we don't understand, that we don't have freely access. And adding to this, as we'll explain, in addition, having already very complex TB referral path as such for as well for the Polish citizens. Further mobility, they don't know how long they will stay, where they will move further. The support system, they don't have family, they don't have their friends, so the whole support is not there. And as you know, among the refugees, majority, they were women with children. And I imagine if, because in Poland, TB treatment was hospital-based. If you think about the separation, when you have a mother that needs to separate from a child for several months, I mean, this is not something that will actually, none of the mothers will do that. Stigma and discrimination has been mentioned as well. It's still a very big problem in Poland and as well among the Ukrainian community itself. So we know of people that they have lost their shelter, they have lost their job because they have been diagnosed with TB. And let's not forget that even though those people are now in the safer place, but the war is really next door. So their loved ones are still there. So they have husbands or sons that's still on the front line. Their families are under bombs. And themselves, they have been victims of the direct violence. So they bring this psychological weight, I can say it, into the already having a diagnosis of TB. And then just simply difficulty to adapt in a new reality. And this I can say as well myself, as I've been a political refugee in the 80s. So I remember very well my movement into Belgium from Poland, and it was really complex let's say, months or even years to start your life from scratch. Now looking to the gaps in the Polish system itself. So we don't have a national TB program. We don't have a strategy. We don't have resources specifically for TB. There's no system of data. There are no protocols. So all of these basics, it's not there. There has been hospitalization approach. So anyone who was diagnosed specifically with drug-resistant TB had to stay for all the time of the treatment in isolation. And it's a system that it's really system-based and not person-based, because it was linked to the financial, let's say, reimbursement of the medicines that were based on the bed occupancy. So drug-resistant TB treatment lasted for 2 years at that moment, and many of the patients in complete isolation, so really like in a prison for this whole time. And in terms of drug-sensitive TB, the patients were actually sent back home and after initiating the treatment, and no one cares if they're actually taking their medicines, if they finish their treatment, no one really cares. Diagnosis, we didn't have in Poland rapid molecular tests, which are now the standards, and many of the patients, they didn't get the initial screening if they actually are resistant or not, so they didn't know if the treatment that was started was the effective one. And the path of patients to get diagnosed as well very complex. And for this, you need medical insurance because you have to pass by the family doctor. And TB become a forgotten disease, so there's not basic language among the doctors, and a very strong stigma that's still very present. Challenges, as Gabriella already spoke, medicines, it's a really, really big challenge for us. So we don't have fixed dose combination. An adult needs to swallow at least 11 tablets a day. There's nothing for children. We cannot do preventive treatment because rifampicin is not there. And for isoniazid, the people need to pay. For drug resistance TB as well, all these fantastic medicines that Gabriella spoke about, they were not available in Poland. And again, there was nothing for children. And so here what we have to say that, so actually the medicines were not there to continue treatment of people who were crossing into Poland. And it's not only the situation in Poland, it's actually exactly the same situation in other European countries. So as consequences, we have a low accessibility and acceptability of TB care in Poland. This, of course, provokes a late diagnosis and treatment. It means transmission is growing. And then as well, the patients, when they reach already the system, they are really in a very complex and advanced situation. And of course, if you don't have proper medicines and you treat people with whatever you find, then you risk to amplify this resistance. So again, for someone who has been working as well in TB many years ago, seeing that for me, it was like moving into the time machine. And then especially if you see in Poland, the TB still be treated in the sanatoriums, which are completely isolated somewhere in the forest, where to reach there by bus, you really have to be very smart to find a place. So we start the project, and the main objective of the project, it was to assure the continuity of the treatment. And then we realized that providing the medicines was not enough, that actually the general transformation of TB treatment and care needed to be, all of this needed to change. So then we start to focus on the WHO standards that needed to be implemented, but as well this whole patient-centered ambulatory approach was needed. Because if not, the people would not come. So as the project already lasts for 2 years, we had an evolution about through this time. So we actually start moving from continuation of TB care to access to TB care. And only from Ukrainian refugees, actually other migrants that face exactly the same challenges in accessing care. And from our role of gap filling, when only we're supposed to provide medicines, to change our role towards a catalyst for change, and this on 3 main aspects. So we speak about access to TB medicines, we speak about standard, WHO standard implementation, and patient-centered approach. So we have 6 components of the project. The first one is the case finding and linkage to TB care. We run an info line. We facilitate all the exchange of medical documentation between the countries. And we link the patients who are actually moving to different countries. Through our network, we move them to other places. Patient support, it's a big component. So everything what's related to education of the patient, psychological support and psychosocial support. For this, we have a team. The supporting medical management, of course, medicines was the most important, but as well the clinical history and TB costing that has been created, and we are part of it. So we can provide advice on more complex cases. Support in implementation of ambulatory care. So we are implementing video supported system. Of course, we do a lot of capacity building. And the 6th component, which is extremely, extremely important, is this whole advocacy that go actually beyond Poland. Because again, the medicines, it's not only Polish problem, it's all over Europe. Our approach, because it's true that as MSF, we used to work in the low and middle income countries. Here we are in the high income country. So we need as well to have a different approach. So it's clearly not a standalone. We work very closely in partnership, already internally in MSF. For us, Access Campaign, it's really vital. So it's Operation Access Campaign, but we as well involve our partner sections in Poland and in Germany. We work very closely with WHO Europe and Poland office. And of course, at the Ministry of Health, all different medical, let's say, entity that are involved at some level in TB. And of course, the numbers of different NGOs and civil society organization with whom we work on the psychosocial support. So our role is really this gap filling, but as well, we are an advisor. We facilitate the connection. So we use the resources that exist, and we are bearing witness. So because of our activity directly with the patients, we know the reality. So we can identify the gaps and we can then propose practical solutions. So it's a very small project. All our interventions are online because the patients are everywhere. So we cannot be everywhere. So everything is done online. We have a very small team, patient support activity manager, counselor, social support, social assistant, and we are very lucky to have a MSF expert on TB who is Polish, and he gives us 1 day per week of his time. So of course, then was the cost of the donation of the medicines and social support, and we have the time frame of the project for 3 years. Our data, so far we managed to support 218 patients, from whom 135 they have drug resistant TB. And what it's important for me in terms of because we don't have, of course, cohort outcomes, but for me, the transfer out is very important because we manage among those 14 patients, it's true that many of them come back to Ukraine, but we're able to connect people for continuation of treatment in Georgia, in Belarus, in Germany, and in Finland. Our achievements. So I think we will be quite fast with our donation of medicines. So at the beginning, we were actually smuggling some medicines from Ukraine to have them in Poland to be able to respond to the first patient's needs. It was a donation that started with MSF, and then WHO amplified this donation for much more patients. Now we are currently in a transition between this donation to the self-sufficiencies of the Ministry of Health. They created a reimbursement system for medicines that is detached from the hospitalization. We implemented this amazing 6-month regimen that Gabriella talked about for drug resistance TB. So no anymore injectable, not anymore 24 months of very toxic medicines. And what's amazing, because Gabriella mentioned it's a very expensive regimen in Poland. Actually, in Poland, it costs about 45,000 euros per patient. But the MOH, with our support, managed to decrease the price of the most expensive medicine by around 40%. So currently it costs about 28,000, still a lot, knowing that it costs less than 400 euros in low and middle income countries. So we were able to implement this ambulatory drug resistance TB treatment. So video supported was introduced already in 10 medical structure, and ministry run a pilot project on that. We have this cross-border mechanism that I explained. WHO this year did really deep program review. They brought 7 different experts. MSF was part of it. And so now Ministry of Health have very clear recommendation in hand to start building the, let's say, different system that needs to answer to those recommendations. The National TB Continuum was installed, and we are part of it. And actually, Poland took an important political role. They were facilitator of last year UN high-level meeting on TB. And they, the Polish government actually run 2 side events at the 2 World Health Assembly in Geneva, focusing on TB. And this year, MSF Access Campaign was invited by the Polish government to speak at this platform on access to TB medicines. We try to be very vocal, as mentioned by Gabriella as well. We are part of Time for 5. It's about the diagnostic, prices of diagnostics, and the tactic. So we are the only European perspective that we bring to those campaigns. We try to be very vocal, trying to get to different conferences. Here it's one of them, international, national. The workshop was mentioned already by Gabriella in Berlin. And we really try to produce, in terms of comms, publications to spread the message, not only in Poland, but internationally. We still have 1 more year to go. We really want to focus on access to medicines, support MOH in implementing the recommendations. We start working on some digital tools for patient support, capacity building. We really need to really boost it. We are doing already a lot. And then, of course, we want to capitalize our experience. And here comes the operational research, because we do believe this experience is interesting, so we really would like to document it. And of course, we would like to find a solution for the sustainability of the whole patient support component. So as a conclusion, arrival of millions of Ukrainian refugees triggered the change in Poland and in European Union. And it's in terms of availability of TB medicines and standard of care. Thank you very much.
Thank you, Joanna. I'm sure the audience has a lot of questions, so keep them memorized. We'll get to them after our last talk. So I think we had now a bit of a history from Guinea. We had the kind of wide array of activities that MSF operates it when it comes to treating patients, operational research, pushing those boundaries, advocating for access. And we had a talk on basically the most vulnerable populations, but also how diseases that might have disappeared all of a sudden can come back, and then we're not very well equipped to treat that most appropriate. And that, I also think, brings us to our last speaker. I'm very happy to welcome here Dr. Anne Vergison. Yeah, please do join. Also a rich history in medicine, specifically pediatric infectious diseases. There we are. And has also worked a lot on infection prevention and control. And after many years now also working in Luxembourg at the Health Directorate, and since 2020, head of division on sanitary inspection. And she will walk through us, help us walk through the tuberculosis situation in Luxembourg in 2024. So there you go. It's just one button.
Well, thank you. It's a bit difficult. We are in a completely different situation, I think, from what we heard so far. And I feel we are in a luxury situation. I wanted to start first with making the difference between infection and disease. It was throughout the presentation from the beginning onwards, and Doctors are quite familiar with that, but maybe not the non-doctors. And we are very much worried about infection, and I think that's a luxury. We also care about disease, of course, but that's not our main problem and our main focus, at least for surveillance in our country. So it's just, I won't go through all the details, but basically, if you look at this, does that work? I don't think, well, you see on this screen? Yeah. If you use them now. Oh, yes. If you see that, that's when you get the infection. I mean, it remains in your lungs or in ganglia, and it remains then forever. It will never disappear, and you will have the infection for life. It is well surrounded there by natural immune cells that will defend your body against tuberculosis. And for the majority of people, it will never go further. But for many children, it will. For at least half of the children less than 5, they will develop disease and get symptomatic and eventually die of the disease, or even before we make the diagnosis of tuberculosis. For some people, they will reactivate, and you see that there, reactivate the disease because for some reason, their immune system is not capable to maintain it, and then the disease can express itself again. That's a problem we face in all the wealthy countries where we still have people that have met tuberculosis a lot of time when they were young, when the incidence was really high, and now we have quite low incidence, but still we have all the people that are developing tuberculosis, and we should not forget that. What we can see if we do an X-ray for any reason is the scars of tuberculosis. With the red arrow shows you the scars. Doesn't mean an active infection, it just means you had an infection once in your life. But that's something you should have a surveillance that should go on to make sure you don't develop disease anymore. The world incidence, we have talked a lot about it. The red countries are the ones that are the most affected. And if we focus on Europe, where we live, I mean, Luxembourg is very small on the world map. You don't see it. You see it hardly on the European map. And you see the incidence in most of Western Europe is below 10 in 100,000 population, except for Portugal, which is quite an important country for Luxembourg, because we have 20% of the population which is Portuguese or from Portuguese origin. In Luxembourg, tuberculosis is a mandatory disease to report. You need to report not only disease by labs and doctors, but also the infections. These have also to be reported by labs. Every time they have a positive result, they should report it to the sanitary inspection, so we are aware that we have a positive infection. Then also for immigrants, there are special laws, different for refugees than for people from third countries, but all of them should be screened when they come from a non-European or assimilated country in Luxembourg. The incidence, as you see there, is not really going down. If you look for since 2005, when we had this data, it's quite stable incidence, and I feel it's really high as compared to other countries. But in Luxembourg, we have a lot of people coming in and out, and we are trying to do our best to maintain that incidence as low as possible. But unfortunately, it has not been possible so far to make it really go further down. If you look at the age groups and the distribution of tuberculosis by age, you see that most of the cases, this is tuberculosis diseases. Most of the disease in the last 5 years occurred in young people. And you will see rapidly why. And one good news is that you have almost no cases, sorry, I should use the mouse, you have almost no cases in children. And that is really a good sign. That means our surveillance is probably quite efficient. Otherwise, I mean, children are really sentinel for tuberculosis. And if you have no children with cases, that means you don't have a lot of transmission ongoing. Then if you look into the countries, you will understand more the age distribution. Most of our cases in Luxembourg come from Portugal, where the incidence is higher, not only people from Portuguese nationalities, but also people from Portugal that live in Luxembourg, that are resident here, but often go back for holidays or whatever, and then they get in contact with their families or friends in Portugal, and with a higher incidence country, and they have more occasion to get contaminated there. And that is something we don't focus enough on in Luxembourg, because we focus more on people coming from third countries, but we don't really care about people within European Union. As you see, the other countries are not really surprised. We have, of course, Luxembourg, that are more the old people that reactivate cases of tuberculosis, but also the refugees. Mainly, the most we have are coming from Eritrea. We have a few refugees from Ukraine with tuberculosis, but not that many in Luxembourg. And so far, it has not been such a big problem. We do a lot of screening in these people coming from third countries. And in the sanitary inspection, we are in charge of the people asking for a work permit or any other reason permit. So I will not be able to show you the numbers for refugees. We have a specific service that take care of all refugees. They are followed by the Health Directorate for 3 months and treated when needed. And I will not specifically talk about these numbers, but we had more than 6,000, almost 6,500 people asking for a residence permit in Luxembourg from third countries, and among them 12% had an infection. For all these people, we send a letter to the prescribing physician asking them to do something, and mostly, as you see, you will see it's young people, so we ask them to give a chemoprophylaxis, and if positive, then an X-ray. And most of this is also done together with the Ligue Médico-Sociale, who is caring for tuberculosis in Luxembourg. This latent tuberculosis is this infection. As you see, again, very young people. So a lot of people coming to work in Luxembourg are very young. And as you see, most of them are in the age where they would benefit for a chemoprophylaxis. And unfortunately, I think there we have a lot of progress to make, because it's not often enough provided to them. These are the results we have so far. I mean, we started only a few years ago to really insist with the doctors to get a feedback from what are you doing, and you are prescribing a screening, then we are sending you what you should do with your screening results when it's positive. Do you do something with it? And not even half of them, if you see 44% in last year, did something and send us a feedback. I mean, maybe the other did something, but they didn't say anything. And only half of them followed the recommendation from the National Conseil Supérieur des Maladies Infectieuses in Luxembourg, which is making the recommendation for infectious disease treatment and vaccination in Luxembourg. So this is not really a good thing, but you know, doctors are really individuals that like to do what they want to do and not really listen to the recommendation all the time. So we still have a lot of work to do with them. To convince them to follow better the recommendation. For some of them, 11% did a different follow-up, and sometimes it's really difficult to understand what they did, and it shows that they don't really know, because it's a forgotten disease, and they don't know exactly what to do. Some of them refer them, hopefully, to our infectious disease specialist that will, of course, provide a correct treatment. And then some of them, unfortunately, think there is no need to do anything, and there is no follow-up unless, again, the Ligue Médico-Sociale will get them and can provide some follow-up to these people. Then last year, we issued some easy recommendation for doctors in Luxembourg with them really easy things. It's only 1 page with the interpretation of the results of your screening test in 1 page for immunocompromised patient, non-immunocompromised patient. Then how do you treat the infection in adults, in children? So they have only 1 page to read. And we hope that they will adhere more to the recommendation, because we try to help them. We will also try and get their feedback from what they did with the patients and whether they followed the recommendations or not. Another specific problem we have in Luxembourg, I mean, it might seem a bit ridiculous compared to millions of cases everywhere, but Luxembourg is a small country. Nevertheless, we have the refugees question. There, the follow-up is sometimes difficult because of the language barriers and other problems, but maybe I saw that there was one of their doctors in the room, and if there are questions, he can probably answer with the refugees. And another problem we have is with the homeless people. There, the treatment is, of course, because it's not a very easy treatment, and it's a long time. Even if you go to 1 month's treatment with a homeless person, it's going to be very complicated. We don't have so many homeless, but every time we have one, it's a big issue to find a solution for the treatment. So we use DOT. I put the definition again. We use the criteria that were defined in the US, but we added criteria in Luxembourg, and I think we have quite broad criteria for DOT, so directly observed treatment. And we also have some adapted directly observed treatment where we just do some visits to help to start with the treatment, to check whether it's properly taken, because some patients, they don't really need for you to go every day to see them taking the treatment. We have the luxury to have more people than probably in other countries to go and visit people at home, or we have also the help of social workers in some places. And that's what we do with DOT in Luxembourg. I mean, it's always a challenge to implement a DOT in Luxembourg. We have around 10 DOT a year to implement, and we work closely with I must say it's a good work with the social workers when we have homeless people, because we can go to the place where they stay for the night shelters. We go also in the social day bistro, and we can provide them with the drugs and check with them that the drugs are given every day to the right person. That's a real challenge, but we managed to do that. But again, I mean, for homeless, we still have a lot of work to improve things. Of course, among homeless, there is a lack of regular screening. Then the diagnoses are often late. And sometimes, I mean, recently we had someone who died, and at autopsy, it was found that he had tuberculosis. He was only 44-year-old, but that was a homeless person, so probably a late diagnosis. Also, it's difficult to keep these people in hospital when they are contagious. Sometimes they don't want to stay in hospital, and it's really a challenge to find a place where we can put them. It was easy during COVID time because we had some dedicated hotels for COVID patients, and we could use this hotel as well for tuberculosis patients. I mean, it was not the first goal, but we did do that, and it worked. Unfortunately, we have no other structure that we can specifically use for these patients that need to be in a place where we can supervise the treatment without them being in hospital and feeling like in prison. So that's always a problem and a challenge for us in the future. Then we have also intervention that we make. Normally, the contact tracing is made by the among the in the family, and work is made by the Ligue Médico-Sociale. We do some specific contact tracing when we have exposures in specific situations, such as schools or structures like a shelter for homeless. There we have more people with a risk of having a heavy contamination, especially in kids in daycare centers or school. We had a few cases with adults that were positive for several months, coughing, and then we had quite heavy intervention to try to avoid further contaminations, or at least further diseases in children. In this intervention, again, we are lucky. We have a lot of means and a lot of people that can go on the places and do screening twice at 3 months interval between the two screenings. We can screen a lot of people every time, and we are very broad in the definition of what we consider as a contact at risk. And then we found quite a few children that were positive. At least 15 children in the last 2 years were screened positive at the second screening. So they really became infected in contact with the positive case. And probably they all received treatment. Of course, in Luxembourg, it's always easy because we have only one clinic that is specialized in care for children and also for infectious disease in children. So we send them all these kids and they are all properly treated and followed. And then probably we avoid further diseases. We did similar work also in a homeless shelter last year. So in perspective, what we have to do, we certainly have to improve the follow-up, not so much on disease, but more on infection and latent tuberculosis. I think we had the question last year from our foreign minister to know whether we should continue screening from third countries. I think we should, because we have a lot of infections that are detected. 10% of them are detected with infection. And we looked at it and we could not identify one specific or several specific countries that were more at risk. We couldn't find an incidence, a cutoff like 20 per 100,000 or something like they do in the US. For us, it was not really a good threshold, and we prefer to screen everything, even if it's a bit costly. But I think Luxembourg is rich enough to continue to do that kind of screening. It's probably cost effective at the country level. Then we need to improve the screening for at-risk population from within European Union, especially from Portugal, but maybe also other countries with a little bit more cases of tuberculosis in their population, and probably working closely with occupational medicine, especially when these people have jobs working with communities of children, when they are teachers or whatever, they should be screened on a regular basis to avoid this situation that we have lived these last years. And definitely we need to improve the care for homeless people, this difficult to reach population like drug user, because we don't want to lose people at follow-up and end up with resistance. I mean, Vic and Pete are there and they know much more than me about resistance, but I think lately we had one multi-drug resistant patient, and that was really a problem to treat. That was a patient from Ukraine. Apart from that, we don't have so many cases of resistance, I think, but they can correct me if I'm wrong on that. And then I wanted to thank all the team at INSA, because everybody is always involved. Our epidemiologists help, and we are all trying to help whenever there is a screening or a problem, and collaborate with the infectious disease at CHL particularly. Thank you.
I'm gonna see if they work. That's good. Many thanks for the overview also of the situation in Luxembourg. Different context, much richer country, of course, than the typical settings MSF works in or other actors work in, but also interesting to see the challenges and opportunities and how cost effectiveness sometimes gets a different meaning depending on context. I think that is important to consistently realize. I want to already start thanking all the speakers for their really valuable insights from different perspectives. And I think in a relatively short time, you've jointly given an excellent masterclass in what is current. And before we switch to the audience, both online and here in the room for questions, I actually wanted to ask the first question, which links back to the initial presentation when I did my scoping exercise around the numbers, around the targets. Maybe if I could ask from all of you, just very briefly in 1 minute, are we on track? Because I think that's what my big question comes down. Maybe Anna could start with you. I'm going to hand you a microphone.
Are we on track with targets? I'm not sure most European countries are. I think we should do more, and especially for screening. I'm aware that when we discuss with other European countries, most of them tend to reduce the screening they do. And I think this screening is extremely important, and we shouldn't stop and reduce that. ECDC guidelines are not really tough on that screening because it's quite costly. But when we see our results, we think it's really effective. And I couldn't find any cutoff anywhere when you can decide or which country is really at risk from importing tuberculosis. So I think we should continue targeted screening, but we should continue to do it.
I'll hand the microphone to you next.
So from my perception of situation in Europe, we're actually not on track. And this is for me kind of very sad because we actually have the tools to be on track. We have now really effective medicines. We have diagnostic tools that are just not available in Europe. So this kind of political will, and this is what we are working on to see how in practice we can get those tools available and affordable in Europe.
Maybe to give a global perspective, we are really off track. So in theory, next year, the TB epidemic should have like really gone down. And countries like India, they declared until a few months ago that by 2025, TB would be eliminated, despite the fact that they have more than 1 million cases every year. We are completely off track across all the targets. Maybe the only target that the targets are available, easily available, and we have these amazing high-level meetings on TB. The last one was in September, where all countries they go and they set targets and commitments, and then we keep being off track. The one target that is actually globally going to the right direction is TB preventive treatment. I mentioned this looking at you, in people living with HIV. There have been some countries as Zambia, South Africa, that really contributed to a big increase of that. But when we look into prevention and all that you mentioned, although in most countries they don't use TST or IGRA because it's complicated and expensive, we are really far away. There are gaps in money, funding, research, implementation, everything. And I'm a big fan of prevention. So I think it's fantastic what you do in Luxembourg. You have big resources, you can do it, but even in an easier way without maybe TST, and so on, we should scale it up, and we try to scale it up in across all countries. Professor, what la direction dans laquelle on va peut-être en Guinée?
Général. C'est vrai que les objectifs qui sont fixés, c'est sûr qu'on ne les atteindra pas. Vous avez vu ce que j'ai présenté, il y a ce taux de succès du traitement qui est très bas, et je n'ai pas parlé de la tuberculose des enfants. Non? Je dis que il y a très peu de chances que nous atteignions les objectifs pour 2025. Peut-être 2035, ceux qui étaient prévus pour 2025, peut-être, parce que le problème de la tuberculose, en réalité, il y a eu beaucoup d'efforts, beaucoup de résultats positifs, mais il reste encore tellement à faire. Et vous avez vu dans le rapport mondial, et lorsqu'on pense aux migrants et à l'impact de la guerre et aux populations déplacées, vous voyez, donc, il reste encore beaucoup à faire. Voilà.
Merci. I'm looking at everybody in the room, and I am half looking at people also online. Are there any questions? Okay. No. Okay. In the room, any questions? Big.
Well, yeah, I have several questions, but maybe the first one to Joanna. Thanks to all the presenters for the excellent presentations. My question, you presented your data on drug resistance, and you said you have 135 patients under treatment, and you say they cost 28,000 per patient. So I did the calculation, that's 3.7 million to 335 patients. So if we put that on a larger scale, how are we going to cope with that even in Europe? And then another question, a very general question, is about latent TB. And Vergison said that was a focus in Luxembourg, but just to remind the audience that latent TB represents 2 or 3 billion people in the world, so about 1/3 of the world population. How can we hope to reach the goals of 2030 without touching the treatment of latent TB?
So yes, you are very right about the price. It's a big barrier to access. In Poland now, because it's true, we managed to donate medicines that were actually not that expensive because of the flexibility mechanism. We're able to import the medicines that cost, was mentioned, about 400 euros per patient per treatment. But so now, when we speak about this transition from the donation to self-sustainability by the Ministry of Health, they set up a system of reimbursement. But even with that, the hospitals, there are many of the hospitals they are not able to pay upfront and to wait months for the reimbursement, because they represent how many salaries of the medical staff. So of course, price, it's a huge barrier, even for high-income countries like we have in Europe.
Anyone else in the panel who wants to say something about it? Yeah, a specific question, Gabriella?
Just to say that the price and the lowering of the price and everything related to patents, it's a massive, it's a very important advocacy objective of MSF. We fight for price reductions all over, and actually some amazing results have happened. But in Europe, we don't even know what each country pays.
I will just add what's incredible, that Europe put a lot of money, Europe and US, in development of those new medicines. So already we invest as countries because it's based on public funding, and even with that, we have no access to those medicines.
But maybe just to say that this dossier that we are working on for access to drugs in Europe really touches on that. Would be great to get Luxembourg on board as well. And then we will continue. If anyone is interested, we are going to have other 2 webinars tomorrow. Big day. But in any case, it's a big dossier with Germany, with many countries and so on, and WHO. We try to push to improve. Also access to rifampicin that could allow you to give a 1-month treatment also to the homeless people. It would be much better, I guess. But yeah, the second one.
No, I mean, worldwide, that seems an impossible challenge, but I think we should have a vaccine. That would be probably the best solution. And it's probably feasible to have a good vaccine against tuberculosis, but it's not a priority because it's, again, it's always a question of money. And but vaccine, I mean, we didn't talk about vaccine, and in Luxembourg, we don't have a policy to vaccinate children coming from high incidence countries. That exists in other countries, in some neighboring countries. At least Belgium, for example, is vaccinating specifically the children from high incidence countries around the Mediterranean region, just because they go back on holidays very often, and so to avoid them coming back with tuberculosis meningitis, for example, and see children dying from tuberculosis in this situation. I mean, the vaccine we have is not perfect, but it's not even used enough, probably, and we definitely need to invest more in a new vaccine development.
Thank you. Also looking at the clock, are there any other questions from the audience? Gilles.
Yeah, just two questions. So you said drugs like rifapentin are not available in Luxembourg and in most European countries. I struggle to understand why that is. Can you give us some explanation? And that's the first question. And then the second one is, I mean, there is a mechanism called compulsory licensing to break patents in case of public health emergencies. And Colombia has recently issued one for dolutegravir, a key drug for HIV. Is this a strategy that is being considered for some of these TB drugs?
So I'll give the short answer, and I'm sure everybody will be happy. So rifapentin is not, let's say, there is no sustainable solution in this moment for rifapentin because it's not registered at EMA level, it's not approved, and it's not, it has no market authorization basically in any country. Crazy. So some countries, and the same applies to pediatric DSTB formulations, and also the adult fixed dose formulation I have mentioned. So the problem is the registration. The registration is a bit complicated, and I'm not a farmer, but in any case, at the EMA, they want more studies. So consider that these drugs, basically, we are saying Europe, these drugs are perfect for Guinea, for India, for Colombia, for other countries, but not for Europe. In Europe, we want more studies, and we want a pre-qualification when basically they've already all been approved, including the different manufacturers by the WHO pre-qualification. So it's crazy, okay? to make it short, some countries are finding what Joanna was mentioning, flexibility mechanisms. So there could be the compassionate use, ways to import, wholesaler, and all that. But the final solution at the end is the registration. And so this dossier that we are working on together with Poland, with the different MOH, with WHO, is really to push for those solutions while, in the meanwhile, finding flexibilities, because some countries managed to use some European laws. There are some exceptions, public health and other, that allowed them to import. That's in a nutshell. Actually, it's much more complicated.
So just adding that, for example, compulsory license here would not work because we are even not looking to produce locally those medicines because the needs are so small that it's even smaller than the batch number of production. So, and as well, the registration, why registration? Again, about the small amount, the small demand, it's not a marketplace. So none of the companies as well, they do not want to bother to register because it's not cost effective. So we have to look for different solutions. And one of them is this flexibility mechanism that allows some countries to import medicines that are not registered. And this is for the moment that we are looking for, and as well to actually request EMA to make a waiver for the registration of WHO pre-qualified medicines for some specific medicines that have impact on public health, but have very low incidence.
Thank you. We have one question online, I believe. Wilma?
Yes, this is it's a question from Monsieur Dr. Moussin. I'm asking about management of TB in conflict areas where we don't have access of medications, e.g. in Sudan. We are observing high numbers of TB cases in Khartoum. We are struggling in access to that area, especially with medical supplies and testing. And we only depend on clinical examination, and we aren't sure on availability of tests. So it's probably more a statement than launching the question, but it's nice to mention that it is if we talk about access.
So the colleague from Sudan or South Sudan, I don't know. Sudan, okay. I was in South Sudan, but it's not the only place where the situation is like that. I mean, we could mention a never-ending list of places where Central African Republic, many. And actually all conflict zones in some cases. So what I having worked clinically a lot on TB, even before we had this amazing test and all this stuff. In these cases, I think you diagnose clinically. You keep a high suspicion of TB, you do an anamnesis, you diagnose clinically, and you give, I know not everyone agrees, but actually I think now the world is agreeing, you give as much as possible the full treatment. Patients are not stupid. So if you spend enough time, that's another issue, to explain, and if we have the right drugs, fix those combinations and so on. That would be, and this is actually what is happening in some MSF projects as well, where we go more and more toward take away package of care. This happens in all the, in most of the migration projects across diseases. So we give drugs that in a way that they can continue their chronic treatment. But I think we should destigmatize also the approach to TB and treat.
I would add as well that I don't remember who presented. It's a tool that actually when the patient receives the full treatment, but it has electronic connection. So actually they can follow if the patient is taking the treatment daily. And I remember from that presentation, they were saying that actually, thanks to that, they were able to follow that some patients were still alive in Ukraine because they didn't have direct contact with them, but they could see that they have been taking medicines every day.
Thanks a lot. I want to conclude with one final question. Maybe Professor, to start with you. With your long overview of the history, also especially from Guinea, but also from the African region, and you look at where we are today, in your opinion, if we could speak to policymakers at this point, and they would joining us in the room, maybe there are any, we never know, what would be your top priorities, recommendations, or worries that you would like to relay?
J'aurais plusieurs recommandations, mais peut-être la plus importante, effectivement, est de mobiliser les ressources pour que vraiment on puisse faire face. Parce que s'il n'y a pas de ressources, vous n'aurez pas de traitement. Et l'exemple que la collègue de Pologne nous raconte, elle est très, très explicite. Et si on mobilise suffisamment de ressources, on va continuer. Donc, ma top priorité, c'est de mobiliser les ressources et de réunir les partenaires pour qu'ils continuent à travailler ensemble. Et si c'est le rêve, on va espérer qu'il y aura des médicaments et un vaccin peut-être pour nous aider dans le futur à éliminer la tuberculose. Mais d'ici là, il y a encore un long chemin à faire.
Merci. Before we go to the formal closure, allow me to give a bit of a conclusion into the evening. I think we started really nice off a bit with the constant battle that we have to kind of like receive when it comes to diseases. They come and go, but they have a tendency to return to us when we neglect our attention, when we neglect the toolbox of interventions that we have. And that typically happens when a disease goes down. You see the attention span that can be reduced. And here is also where the importance in terms of knowledge retainment that Professor also mentioned with training, and it actually came back in many of the presentations, are really important. Fostered into networks within your country, between different experts, within regions, and even in the global stage with global actors that can really help each other in a time of need, but also strengthen a joint advocacy agenda. The elements of stigma are alive as much today as they were a thing of the past. Of course, much less, but they're still there. And they're also definitely a barrier in terms of access to healthcare or proactively seeking healthcare at the earliest stages of when people feel sick. And that's an important thing also, I think, for me and for others in this room that like to look at numbers as epidemiologists. Between everything that we can count, there's also a lot we don't count, or that we miss, or we can't count. And behind that, there's people, and there's families, and there's disease burden, and there's interruption in their regular life. And it has a very severe impact, as was mentioned also in the presentations, of being able to go to school, being able to go to work, to get food on the table. And that's a really important aspect of it all. There's been many elements, I think, across the presentations around pushing the limits, whatever the limits might be. The limits when it comes to innovation in diagnostics. That can be stagnant, or sometimes it's vendor locked, and there's one company that produces amazing tests and therefore also has complete control around the prices. And of course, that is an issue, as we have seen also during COVID, when we're in desperate need for reagents to actually test people before the rapid diagnostic test came available. It's kind of a universal mechanism, but we tend to forget it after every health emergency, how important this is to understand how diseases work, how high the burden is, but most important, to treat patients timely and most appropriate. And of course, when it comes to that unclarity around price points, the lack of transparency, sometimes willingly created by strong lobby mechanisms that fail to explain why certain drugs have to cost 28,000 in one country and 400 euros in another country. And having worked in a bit of R&D on vaccines, I still can't wrap my head around it from a logical point of view. We all believe that, of course, investments are needed for R&D, but it's also true if we objectively look at the profits that some companies make, there is a possibility for finding a nice middle ground that benefits patients. We talked about vulnerable populations, especially those that are on the move and cannot always follow their treatment regimens, but are also living in conditions that are the most optimal conditions for transmission, are the optimal conditions for disease progression because of malnutrition, co-infection due to other pathogens. We spoke about MSF as also in this area trying to fill the gaps as an organization. MSF is an advocate, but MSF also never working alone, working strongly with national stakeholders, being present in global networks to jointly join on advocacy, but also provide technical expertise and going on with clinical trials where others sometimes forget how important they are to advance the field. To conclude, healthcare is political. It always has been, regardless of the setting where you've been. If you talk about the diseases that which we have dropped the incidence or big pandemics, it's about access. This means that also us as health professionals and people supporting health professionals need to be actively engaged in advocacy. We need to push for structural change. And that is also something that the MSF Access campaign has proudly worked over on the years, and many changes have been introduced to that. So with that, I would like to conclude at least this part of the panel, and I would like to thank all the panel members coming from far or closer by to join us. It's a nice mini conference. I hope that all of the audience, both online and here in the room, learned a lot tonight and actually might have left with more questions. And I'm going to give the word to Sonja and Vic for the official closure.
Well, thank you. Thank you, Amrish, and thank you very much, dear panelists. It was very insightful, very instructive. I've learned a lot about tuberculosis, and I'm sure I'm not the only one. And thank you, Vic, also for helping in the organization, and of course all my colleagues from MSF Luxembourg and elsewhere. And thank you online for your attention, questions. It will be recorded, so we will propose also to watch it again if you missed some parts or if you want to review some numbers. And I have a little present for our speaker before we go and refresh ourselves. So it's a little present and souvenir from Luxembourg and from MSF. Not only from for the Guinean people, for everyone. Well, you know
Sonia,
Luxembourg, but
We
still.
need a big applause for you because you've been the everything behind this event. You've been coordinating, organizing, coming back to us.
That was a pleasure.
Sonia, you've been fantastic.
Thank you. And we can have some eat and drink and ask more questions if you still have some. Thank you. Thank you, Vilma.